very pleased now to introduce Dr. Karen Davison and Dr. Pulindu Ratnasekera. Please forgive me if I've got that wrong. Dr. Davison is a Canada Research Chair in Nutrition Informatics and in the Faculty of the Health Program at Kwantlen Polytechnic University. And Dr. Ratnasekera is a PhD candidate in statistics at Simon Fraser and a research associate at the same at KPU. And I'm very interested to hear your talk about this and health research and sex analysis. Thank you.
Great, thank you, Lisa, for that great introduction. And I would also like to thank CINS and GAPIO for inviting us to present. So this presentation is focusing on why it's important to consider sex and gender analysis, not only in health research, but also from the practitioner point of view and policymakers calling upon research that's done in this way so that we have stronger evidence in which to support decision-making. So the main takeaway messages from our presentation is to really highlight the relevance of sex and gender analysis. We're going to go through a couple of examples, my colleague Pulindu and I, where mental health and physical health are outcomes and where there were sex differences that we found in that analysis. And then finally, we just want to, again, kind of revisit the importance of gender-based analysis, which is much less common, but hopefully will be more common as we move forward in doing health research. So when we think about sex and gender, I think we do, most of us would know the distinction. So sex is the biological attribute or construct that distinguishes male and female according to genetics, anatomy, and physiology. It influences things such as our risk for disease, how that disease is going to manifest, as well as how we're going to respond to treatment. So we have different pharmacokinetics, pharmacodynamics that occur. On the other side, we have gender, which is more of this fluid construct, which looks at social differences between men and women that can affect how they perceive their disease, what sort of services and programs they're going to access, what sort of decision-making they're going to make around treatment, as well as the response to treatment. So we know that these experiences with gender can also affect the epigenome. There's these epigenetic modifications that can occur as a result of these experiences that alter gene expression. And we often think of sex and gender as sort of the end user perspective, but there's also the perspective of the practitioner. So depending on whether the practitioner is a man or woman, that can influence how treatment is provided. So for example, there's been research to show that in the area of arthritis, there's a tendency to have men go on for surgical treatment to treat their arthritis, such as a joint replacement, where there is less tendency for women to get that kind of treatment and be treated in other ways. So what we'd like to do now then is just to highlight a couple of examples of analysis that we have done that look at mental health outcome and physical health outcome, and we're looking at sex differences. So the first example here was an analysis of the Canadian Longitudinal Study on Aging. So for those of you that might not be familiar with this, it started about 8 to 10 years ago, and they're tracking Canadian adults between 45 to 85 years of age across Canada, and they hope to track them for over 15 to 20 years. So what I'm reporting here is actually the initial wave of data that they collected. So it's a cross-sectional analysis. And our purpose was to look at immigrant status in relation to depression. And in addition to that, looking at other factors or controlling for other factors to kind of see what that relationship was. So our outcome measure was depression measured by a standard scale. Our exposure was immigration status. So we want to look at recent immigrants, so those that have been in Canada less than 20 years, longer term, those that have been in Canada more than 20 years, and then looking at a number of different covariates. And so this slide, just to kind of walk you through what it's showing, is the stepwise modeling that we did to examine the association between immigration status and outcome of depression. So before we even did that, we wanted to see if sex and immigration status interacted. So that was a separate analysis, and we found that there was interaction, which would mean that you would separate out looking at differences among men and among women. So what you see here, the dotted line is what we call the null value. So if the confidence intervals, so the sidelines there, cross over that, then it means that it's not significant. And as I mentioned, stepwise model. So the first model is just the basic model where age and immigrant status included. The second model includes factors such as education and income. The third model includes physical health factors such as comorbidities, the experience of chronic pain, having hypertension. The next model included health behaviors such as drinking, smoking, and physical activity. Model 5 included factors of overnutrition, so looking at BMI status, body fat percent. Model 6 included undernutrition measures such as bone density and grip strength, which is an indicator of malnutrition. And then our final model included dietary intakes of, say, fruits and vegetables, chocolate, omega-3 fatty acid sources, calcium sources. So you can see these odds ratios, so the ones in red are the women, were much higher and significantly higher for women. So in some cases, in our final model, you could see that the odds of depression for immigrant women was more than 2.5 that of men. And for men, it was not significant. Then we went on to look at longer term immigrants, and you can see there's still a difference. Women had significantly higher likelihood of depression, even if they had been in Canada for more than 20 years. And we were interested, we looked at the literature and we asked people who are working with immigrants, so different agencies and that, as to why this might be. And it seemed consistently we were getting that, well, for immigrant men and women, experience is different when they arrive to Canada. Men will tend to get into the workforce and have a social group around them, whereas women will have more of those gendered roles, such as being in the home, looking after the children, doing those kinds of tasks. So they're likely to be more socially isolated, which is, of course, a risk factor for depression. So our conclusion from this was that we did find that there was sex differences among our main outcome of interest with immigrant status, but also among many other factors, which could inform both nutrition and mental health education interventions. So now I'm going to hand things over to Pulindu, who's going to talk about our other project.
Oh, sorry. Thanks, Karen. So in our second study, our main goal was to understand the importance of the main goal was to understand the importance of dietary chromium in human body. So in order to understand this, what we did was we tried to understand the association between blood chromium levels with common health conditions such as cardiovascular disease and diabetes. So we did this among adults. So we looked at a sample of individuals who are 40 years or older, and we looked at a data set from US National Health and Nutrition Examination Survey. So we had roughly around 3,000 odd individuals, and out of that, about 48% were males. Males. Karen, we could go to the next slide. Yeah. So here, so I'll just quickly go through some of our data. So as I mentioned earlier, we were interested in identifying the association between chromium level and the health diseases. So two of our main outcomes were cardiovascular disease and the diabetes. Both of those outcomes were recorded as binary outcomes in our study. Basically, if a person is diagnosed with cardiovascular disease, such as the congestive heart failure, heart attack, or stroke, they were coded as 1, and others were coded as 0. Similarly, for diabetes or prediabetes, they were coded as 1, and the others were coded as 0. Our main independent variable was blood chromium level. So it is known that the normal or the healthy range for blood chromium level is from 0.7 to 28 micrograms per liter. So anything below 0.7 is known to be low blood chromium, or like it's abnormal, right? Apart from this independent variable, we also had we looked at some other covariates which are categorized into socio-demographics, biological, and health related. And also I should mention that we were mainly interested in including the sex as a covariate to understand the differences in findings between males and females. So next I will go quickly through some of our findings. First, let me go through some of the findings related to diabetes, right? So here again, we have some odds ratios, odds for men and odds for women. So as Karen mentioned, so anything that does not overlap on this vertical line shows significance. So we only show some significant results. And anything to the right of the vertical line shows indicate that the odds higher odds for diabetes. Anything to the left of the vertical line indicates the lower odds for diabetes, right? So as I mentioned earlier, we were mainly interested in the low blood chromium level, and our findings indicate that those who, whether it's male or female, those who had low blood chromium levels indicate higher odds of diabetes compared to those who with normal levels of blood chromium, right? So we saw a significant association between blood chromium and diabetes. And if you look at the data for men, we were able to observe that men who are 50 years or older tend to have higher odds of diabetes, and this was not visible among women. Furthermore, if you look at women, we can see that those who report no alcohol drinking tend to report high odds of diabetes compared to those who use moderate levels. And we also saw some interesting result here, because even though it was for women, the no alcohol and diabetes was significantly associated. And actually, it reports high odds. But for males, it's completely opposite. Actually, among males, they have lower odds of diabetes for those who do not drink alcohol compared to those who have moderate levels. So mainly, we can see that there is an association between blood chromium level and diabetes, whether it's male or female. And also we see that the results vary depending on, some of the results vary depending on whether males or females. So let's go to maybe next slide. Next we have some findings related to
who's a writer and filmmaker and creator of Crossroads 2020.
So next we have some findings from the related to cardiovascular disease. So again, we have some odds for men and women. So here, if you look at men, we can clearly see that the lower blood chromium level indicate higher odds of cardiovascular disease compared to men with normal levels, but this was not visible among women. So there's actually discrepancy, right? And we also saw that men who are married or who live with a partner has high odds of cardiovascular disease compared to men who are single, separated, or widowed, right? And this was not visible among women. But if you look at women, those who are with secondary education or more, we could say like educated, those who are educated have higher odds of cardiovascular disease compared to those who are less educated, and that's not visible among men. So again, we can see that first thing that the chromium level is associated with cardiovascular disease, but it is only among men. And again, we see the importance of incorporating sex as a covariate in our model. So with that, I'm going to hand over the talk. I'm going to pass the talk to Karen again. She's going to do the rest.
Great, thank you, Pulindu. So what Pulindu and we're trying to illustrate here is stratified analysis by sex and showing where there was differences with our main outcomes of measures and exposures. So blood chromium, and then with the other example being immigrant status. And you can see that there's important differences. And this is just one of many examples that you will find in the literature. However, I want to highlight that it's great to do sex-based analysis, and then that's kind of where it's traditionally been, but we also do need to consider gender. So gender identity, gender roles in our analysis as well. So I like this figure that was from the Canadian Journal of Cardiology, which examined sex and gender research in more depth. And we know that there's traditional risk factors that are related to cardiovascular disease, non-traditional risk factors. Those interact with biological sex and with gender. And so in order to capture this better, they make 3 key recommendations. So one is that we do need to do sex aggregated data for traditional and non-traditional risk factors, which is what we've sort of showed here. And you can show that there's see that there was important differences. We need to understand that there is this intersection between sex and gender, and that we need to do better at also measuring gender in studies, and including those in, say, regression modeling and other types of studies, to really be clear about how we can implement better interventions, both for gender diverse people. So some examples of gender measures include the BEM sex role inventory, the masculine gender role stress scale, and more recently, Statistics Canada has used their labor force data to come up with a gender index, which could be used. And this is comprised of information on whether the respondent was the primary earner in the household, their personal income, number of hours and responsibility for housework, and level of stress in the home.
Karen, I apologize for interrupting. I'm just looking at the time. So we've gone over a little, and we do have a couple questions. I'm just wondering how many more slides do you have, or how much longer?
2 slides.
Okay,
yeah, we're on the key. Yeah. So just from this, our key points and recommendations, we highlight that health systems are not sex gender neutral. As researchers, practitioners, we need to commit to conducting and utilizing health research that includes both sex and gender analysis. And this is going to bring about stronger health research, which is going to then allow for better recommendations, more strategic and targeted interventions and programs, more effective policies, improve health outcomes, which of course then reduces healthcare dollars. And what's important, I think, to myself, is reducing gender inequities. So sex and gender is just one consideration. We need to also look, once we kind of have that down pat with our analysis, we need to look beyond and think about intersectionality. So these other factors such as geographical location and culture, and incorporate those into the analysis and how those interact with sex and gender. So these more identity-based approaches. So thank you very much for, again, inviting us here. And we'd like to just open the floor for any questions.
Thank you both very much. That's very enlightening work that you're doing, and I think even we're seeing in the chat box, people are, referencing the importance of that work. One of the questions that we have is the knowledge mobilization, knowledge translation, your thoughts around that. Like, how do you, your plan on getting this knowledge into the hands of the policy and the decision makers, or what barriers do you see in being able to do that knowledge mobilization?
Yeah, I mean, the knowledge dissemination piece is critical, right? You want it to go beyond just, reporting the findings. You want to get it implemented into health policy and practice. So we do try to work with different groups locally and kind of more on the national scale, say in mental health, so the Mental Health Commission of Canada, and more locally groups such as Diversity, for the immigrant piece, like that there needs to be more targeted interventions here to prevent depression in this group. With our more recent study here with the Chromium, the knowledge dissemination that we've done there is just starting. So one of the critical pieces about that work, which we didn't highlight, is that there's been this debate about is chromium even an essential nutrient? And so there's some countries that have it as part of their recommendations, dietary reference recommendations, such as Canada and the US, whereas in Europe, they say they don't think there's enough evidence. So this piece was to kind of bring forward that evidence by showing blood chromium levels in association with these health outcomes, that we really kind of need to lend support to that. So that's another dissemination piece, and we'll be presenting that at the European Society for Enteral Nutrition and Clinical Metabolism later this year. As far as barriers for uptake, it's just getting people to look at this, and of course they recognize that it changes how they must practice and do policy. So the barriers will be really emphasizing how important this is, and to making change, and to making better lives. So some people, I guess, on the end user part that uptake this knowledge, that might be a barrier for them, is in terms of the resources that would be needed to address this.
Perfect, thank you. And one other question. Go ahead, Lisa.
Just want to thank you very much for your presentation, and also just to help us all sometimes get our head around these concepts now that we talk about so much of sex and gender. And I had a patient recently who taught me a lot. And what we took away from that conversation is that we really divide these things into 4 categories in a way. 1 is your biologic sex at birth, 2 is your gender identity, 3 is your gender expression, and 4 is your sexual orientation. And I just was really pleased to hear you try to frame that in that way, because I know this patient taught me a lot about how to be sensitive to patients and ask the right questions.
Yeah.
Yes.
Another question is, as we're evolving and the role-based care and things is evolving, how does that play out, or have you seen that in any of the work that you're doing? So that the homes are now going more towards men taking an active role. So it's certainly an evolution, right? But are you seeing that play out at all in your work? Like basically, this is kind of where I took the question from, interpreting the question. It's like there's a little bit of a shifting in our landscape, and does that impact the work that you're doing?
So if I'm interpreting your question correctly, so sort of where we see males maybe going into more female traditional roles in healthcare, right?
That's the way I understand the question.
Yeah, and that is a very good question. So I'm just going to talk a little bit from the perspective of being a dietitian. So traditionally, it's a female-based profession. We do have some males that are in the profession. And I would say about 10 years ago is when we started, maybe 15 years ago is when we started to see that. And it created kind of more interesting dynamics in terms of the end user. So traditionally, again, we would mainly see women. Women were sort of more receptive to seeing dietitians. And if it was a male or man, typically when I was working in diabetes, it would be, you know, if they were coming to talk to the dietitian, oh, I need to bring my wife along because she does the cooking, right? So it's kind of, so, but I think now when we see more men as dietitians in that we now are seeing that more men, in a sense, are taking more responsibility for their health. So for the cooking and like, you know, that it's not just that should be more of a shared role. So not sure if that's answering the question. And I think there might be some others here that could speak more from other professional standpoints, but that's just what I've seen within my profession.
Perfect, thank you. And I had a question that came directly to me, Pulindu, that is more about your research, but in lieu of time, I'll ask the question, and if you wouldn't mind putting the answer into the chat box for everybody, and then the person who asked will get it. But the question was a bit more clarification around the non-use of alcohol. So in your slide, you had a slide there about the non-use of alcohol and the differences in the men and in the male and the female outcomes of your research. So if you wouldn't mind just explaining that a little bit more, if possible, into the chat box.